Hello, everyone. This talk is about neonatal resuscitation. Most of the information is, of course, taken from the 9th edition of NRP, Neonatal Resuscitation. So we highly recommend that you have that textbook, either buy it or there is an online version, ebook. It's very nominal price. So that's the base of it. So let's start the presentation. So let's see, the EMS called the ER, they are bringing a pregnant woman with leaking amniotic fluid and labor pain. The woman is contracting every 3 minutes. So what are the questions you need to ask? Okay, the first question you need to ask, what's the gestation? Because your plan in emergency room depends upon, if it's term, preterm, and how preterm, because you might have to activate your NICU team to come and help you in the ER. What about the second question? Amniotic fluid. Here the advantage is, that's leaking amniotic fluid, but we don't know. Is it bloody, meconium? Because if it's bloody and is coming after an accident, of course, your course will be different. If it's meconium, your course will be different as compared to clear. If it's foul smelling, you know that you are dealing with infection or chorioamnionitis. What about any other risk factors? How many babies are there? If it's twin you are delivering with, there's an accident, there's a fall. What preceded this labor pain and the mother is coming to the ER? And the last question is about umbilical cord management plan. In ER, it's not that relevant because usually the delivery is emergent in nature, but it's good to know. And I will talk to you about resuscitation in different areas. Just bear with me. So what about this baby? Are you going to resuscitate this baby? Again, I will leave this open. Now, neonatal resuscitation. So like I said, different scenarios have different, the guidelines for neonatal resuscitation. Most of the NRP guidelines are relevant in delivery rooms. So if you are in the hospital and the delivery is happening in the delivery room, it's much easier and controlled. You can follow NRP, most of the recommendations, and it should be okay. In emergency room, just like the case we presented, it's still in hospital, so you can get the NICU team right away, but again, some equipment and some details will be different. What about if the delivery is happening in urgent care or a clinic? The mom just goes there and deliver. Of course, that again differs from the delivery room delivery. What about if the delivery is happening at home? What about if a resuscitation need is in the postnatal ward? A baby in the nursery get an episode of desaturation and stop breathing. What you're going to do when the baby is in postnatal ward and nursery? We'll talk about it. And what about an infant who is being monitored in the NICU and suddenly the nurse call you for a cord? The heart rate is going down, baby's bradycardic, baby's desaturation. So the point which I want to make is that neonatal resuscitation, the basic principles applies the same, but there are certain differences in the area where the delivery is happening, and we are going to walk you through. So now let's start. Of course, the history is very important. What is, in any case, wherever the resuscitation is happening, relevant information is very important. For example, if a baby is in the nursery, we need to know what happened. Was the baby feeding before the delivery? Maybe baby choked on the feeding. What about like emergency room? We talked about if there is a motor vehicle accident, then of course the whole course will be different. What about equipment, especially when you are outside the delivery room? Like especially the delivery happens at home, the EMS has to have all the equipment available. What about if the baby is in the nursery? Most of the equipment is not available readily in the ward when the baby is rooming in with the mother. So the point which we want to make, that equipment sometime are not readily available in certain areas as compared to delivery room, which is equipped to have resuscitation for newborn infant. Personnel is very important. You have to have trained staff, and we know that there are two courses now. One is essential and one is advanced. In essential, basically those who work with postnatal ward or labor and delivery, they need to know at least to stabilize the baby up to ventilation part. By that time, the skilled staff will come, and intubation, cardiac compression, medication, this is beyond the scope of essential, that is in advanced. So again, knowing your personnel and trained staff is very important. Of course, you don't have to memorize the flow diagram, but you have to understand the flow, how thing goes. In real scenario, from one step to other step, it's a continuum, but it's good to follow what NRP recommends, and we'll talk about the flow chart. And of course, like I talked to you, if you guys have NRP certification, again, remember, NRP does not certify like it's not giving you a degree or a certificate that you are good to go with resuscitation. It's just a course. It just NRP just says that you have completed the course. So it's not like a certification, although we use this word. But again, this is just NRP just basically says that you have completed the course. So this is the flow diagram which we were talking about. So most of the time we are going to refer to the delivery happening in the delivery room, but again, you can improvise depending upon which setup you are. So this is an example, a delivery is happening in the hospital, in the delivery room. So of course, the first, question before delivery, like we talked about, you have to ask few questions. So these are the questions. You can remember it with the mnemonic like GURU, which is gestational age, amniotic fluid, risk factors, or what is the plan for the umbilical cord management. The next after delivery 3 questions are: if the baby is term, what is the tone, and is the baby crying or not? So these are the other factors. Then of course, after that you need to know what are the initial steps. So this is the flow diagram which we talked about. The main thing which is listed in the box here is that you have to maintain the temperature. This is very important, that you should maintain the temperature. And the things which we have changed in the new NRP is that you don't have to stimulate the baby and suction the baby for pre-secretion. These are only if needed. Remember that drying is stimulation, so you don't have to again do the same thing for the baby. You are basically, when you're drying, you're stimulating. So remember, the steps has changed. So so keep the baby warm, keep the baby dry, but remember that babies who are less than 32 weeks, you don't have to dry the baby, and then position the baby. By this time, the baby should be crying and baby should be breathing, and you should be all good. If not, if baby is gasping or having apnea and the heart rate is below 100, at this point, you have to start ventilating the baby. And there are many ways you can ventilate. In hospital, you can use TPs, anesthesia bag, which are again called self-inflating, or you can use the like we said, self-inflating bag. Anesthesia bag is flow inflating bag. So there are different ways. Whatever your hospital has, just follow those. So now again, the question we talked about, then the other one is assessment, and the last one is initial step. Remember that stimulation and suction is only if needed. Now, the thing is, what is the umbilical cord management plan? So there are 2 things you can do. One is, of course, deferred clamping. So 60 seconds, you should just wait and put the baby on the mom's belly and just let the flow come from the placenta to the baby side. The other thing is you can do the milking of the cord, and we're going to talk about it. First of all, why we do that? So in the advantages of the benefits are, in preterm infant, it has shown to decrease the use of blood pressure medication and of course the need for blood transfusions. But the risk is hypothermia. The longer you keep the baby away from the warmer, the baby could be at risk of hypothermia. So you have to weigh the risk and benefits. In term babies, it has shown that hematocrit is increased, and also because of the increased hematocrit, there is increased need for phototherapy. But again, basic idea is you have to give the benefit of this placental blood there to be transported to the baby by deferring the umbilical cord clamping. So if the baby is vigorous, irrespective preterm term, you should do at least 60 seconds. Some centers do 30, but 60 seconds is what NRP recommends. Then immediate clamping is needed if there is an acute event, just like in emergency room, you're suspecting any abruption, you're suspecting any cord problems, avulsion of the cord, or any accident there. You don't have to do the deferred clamping. You just have to deliver the baby and give it to the team waiting for resuscitation. What about cord milking? Again, if the baby is not vigorous, you again want to give the benefit of that placental blood to the baby. So you milk basically the cord from the placenta towards the baby. So if the baby is less than 28 weeks, of course, it's not recommended. Between 28 and 34 weeks, it lacks evidence. But if the baby is greater than 35 and baby is non-vigorous, just do quick milking so that whatever benefit you can get to the baby. So now a little bit talk about the amniotic fluid when it is meconium stained. Just remember that basically we need more than one attendant for meconium delivery. The reason is that meconium stained fluid basically is telling you that the fetus is in distress. So you have to do something, beyond the resuscitation. So you need 2 providers for that. Then again, remember there is risk of meconium aspiration because and it can cause meconium aspiration syndrome. And of course, you need the kit, which is listed, which is shown below. There's a specific way you can suction that, and you need two qualified person and more if you suspect other problem. But remember, for meconium, you have to have two skilled people going and attending their deliveries. And what about the resuscitation part? So there are two ways. If baby is vigorous, of course, you don't have to do anything. Just follow the initial step of resuscitation, which is dry, warm position. And like we said, stimulate and suction only needed. In meconium baby, if you see the fluid is already there in the mouth, just suction it, and you don't have to wait and follow all in the order. So if you see that the baby has secretion in the mouth and the nose, you suck it, of course. What about if the baby is not vigorous? Again, you follow the same steps, try to suction it, and the whole idea is there's just doing the basics initial steps. But again, remember that NRP is not recommending routine intubation. So it was a practice, a few years back, that all meconium babies used to get intubation, but the data showed that it's not really beneficial. So again, remember, in summary, meconium management is easy. The only thing is, if you are working in a hospital, there should be two providers available to attend that. The second thing, you don't have to intubate babies with meconium aspiration or suspected meconium aspiration or meconium stent fluid. Just remember that. It's so easy. Now, what about ventilation and oxygen therapy? Again, like I said, follow your hospital equipment, strategy. If you have a T-piece resuscitator, you have a flow inflating bag, you have a self-inflating bag, whatever your unit use, get yourself familiarized with the need and with the equipment. So basically, when should we start ventilation? There are three things. If the infant is apneic, gasping, of the heart rate is less than 100, you should initiate ventilation. What is the rate? The rate is 30 to 60. And how can you remember that? Just say breathe 2 3, breathe 2 3. This way, when you are bagging, you are making sure, or if you are using the T-piece resuscitator, this is the way to remember that you should do the right ventilation rate. So what about the pressures? Pressures on greater than 32 weeks, you can use between 25 to 30. The PIP, which is the peak inspiratory pressure. And in smaller babies, less than 32 weeks, your pressure goes down by 5, so it should be 20 to 25. Again, remember, PEEP is the same in both cases. So what is the indicator your ventilation is working? Of course, with the chest is rising with the ventilation, the heart rate is improving, is rising, and you have a saturation that is going up. If your ventilation takes long time, it is highly advisable that you should consider intubation and try to insert the orogastric tube to decompress the stomach. Again, continuing with the ventilation and oxygen therapy, two things are very important. When you are using, bag and mask ventilation, it's always good to have your CO2 detector connected, especially when you are using the LMA. The advantage of LMA is that anybody can insert it. You don't need a laryngoscope to do that. And so one can do that, and you can attach the CO2 monitor to see if your ventilation is happening right or not. There are different types of LMA. You guys can read on the textbook about it. Some are like, without the air inflation. The others are, with the inflation. So it depends upon whatever you want to use. The other thing, when in ventilation, if the things are not improving and you think that you're ventilating it okay, always follow the Mr. SOPA, which is listed here, that, mask adjustment, reposition, suction if needed, open the mouth, increase the pressure, and of course, using the intubation or laryngomask. The things which have changed in 9th edition is you don't have to follow this in order. If you feel that everything is okay initially, the mouth is open, or you can go and increase the pressure, you can insert the LMA. You don't have to follow the sequence of Mr. SOPA. So, and again, if ventilation is happening for long, consider intubating earlier than later, and of course, decompress the stomach because you have been bagging the baby and the air is going through the esophagus to the stomach. Releasing and decompressing will further increase the lung compliance. So this is Mr. SOPA. We talked about it. Few words about oxygen therapy. You can pause the slide and look into it. Remember that, always use blender. Do not give oxygen just based on the color because you have a pulse oximeter. Follow the guidelines, which is target saturation. So again, you guys can read it through, and there are different equipment which are listed here. So this is what we are talking about. So by 2 minutes, the oxygen saturation would be around 65 to 70. And again, this box represent that oxygen saturation increase by 5 to 10% every minute. So if it start in 2 minutes as 65 to 70, just increase 5 to 10, 5 to 10. So by 10 minutes, the baby should be around 85 to 95. And few changes on the requirement of using the fraction oxygen. So for bigger babies greater than 35, use 21%. Between 32 to 34, you can use 21 to 30%. And small premature babies less than 32 weeks, you can start with 30% and titrate it based on the oxygen saturation target. Again, remember, oxygen is a drug, so you use it judiciously. Now, let's talk about cardiac compression. So, as you remember from the algorithm, if you have done full 1 minute of ventilation with everything, Mr. Soap, all steps are followed, and the heart rate remains less than 60, you have to start cardiac compression at this point. And again, remember, cardiac compression is not the primary thing in newborn infant. Newborn infant usually their usual problem is ventilation. So again, but if you have to do based on the flow diagram, just follow this. And again, when to do, what to do, and how to do, this is the area which you should be using for doing the compression. And again, this is the details of how you do it. So basically, remember, you have to do 1 and 2 and 3 and breathe. So this is the way we do 3 in 1. So again, even if you are in the NICU, the NRP strongly recommend that you follow this rather than doing the 30 and 2, which the PALS recommend. So the cardiac compression ratio still remains what NRP says, even if you are in the outside delivery scenario. Just follow that. And again, you can pause the slide and review it. So again, intubation is not something which we can show in the PowerPoint. It's a skill, and we have included 2 links. One is nrplearningplatform.com and other one is arp.org. There are nice videos available if you want to learn these skills. It is highly advocated that you go to the skill stations when you go for your practical scenario and exam. Just practice it there. That's much better than theoretically learning it. But watching videos do help. In the new textbook, there are the scan code bar. You can just scan it from your cell phone and watch there. If you are a computer desktop person, you can do it on the desktop. But again, skills are skills that are learned by doing it. So this is something about pre-calculated epinephrine. So now you know that 0.2. If you remember the dose 0.2 ml per kg, you'll be always right if you're in trouble. The NRP now has a nice table. If you guys can buy it from their website, you can put it in your delivery room. So you don't have to really calculate, well, the all stress is going on. You have something printed and posted in the delivery room. If you are in ER, you can do that as well. If you are an EMS, then there are certain cards available which you can buy on the AAP site to know, and you can just look at that dose and give it to the baby. So there are many resources available in every setup. If you're in the clinic or urgent care, you can follow that. If you are in the nursery or postnatal ward, again, you can post it there. These posters are available. They are laminated, so they are okay with the infection control. But do check with your infection control team that if it's okay to put all these charts in the areas where resuscitation happens. So again, in summary, we start with, of course, I hope ideally we know what we are dealing with, but surprises can happen. So you start with 3 questions after birth. If it's term gestation, if the baby is breathing with good tone, if that's the scenario, the baby stays with the mother and you don't have to do much about it. Just follow, provide warmth, and make sure that baby remains okay. If the baby is not one of the 3, and so you go ahead and start initial steps, which is warm, position, and dry. And by that time, the baby should be breathing and you don't have to do anything. But if the baby is still gasping or having apnea and the heart rate is less than 100, if you are there now, then of course you have to do something, and you have to start ventilation by, like we talked about, whatever equipment you have, just start ventilating the baby. At this point, consider connecting the baby to the pulse oximeter, and you can even connect to the ECG monitor at that point. So now it goes further. Heart still remains less than 100. I'm not going to talk about the right side because if it's no, then the baby will be okay. Like for example here, if the answer is no, then we know we don't have to do much. You just follow these boxes. So that's easy. So now, so we are here now. The heart rate still remains below 100. So what should we do now? You follow the ventilation corrective steps, which is Mr. SOPA. And again, remember, you don't have to do in the same order. You can do laryngeal mask, insertion earlier, but make sure that you have cardiac monitor available by that time, because counting the heart rate while cardiac compression is going on is difficult. But if the heart rate is okay, it's coming up, you don't have to start cardiac compression. Remember, cardiac compression is almost like a last resort. Usually, by following the earlier steps, the baby should be responding to that. So now, despite of correcting all that, the heart rate still remains below 60. This is the time we think of intubating the baby or putting laryngeal mask, start cardiac compression, and remember the coordination combination with the ventilation is 3:1. Just follow that. And you should be thinking now about, of course, increase the oxygen to 100% by now, because during CPR, the oxygen delivery is compromised and oxygen demand is increasing. So it's good to have the oxygen jacked up to 100%. At this point, you should be considering the IV access. If you are in the hospital and in delivery room and in nursery, of course, UVC, umbilical venous catheter, is the best choice. But if you are in the field, if the delivery is happening at home, then the interosseous would be the better option, because you can EMS are trained in doing that, so that's not really a problem. So if the if heart rate remains below 60, at this point you should be considering giving medication, which is epinephrine. And again, like I said, the dose is 0.2 ml, just for remembrance, but you should follow the chart which is available on the AAP side. If your heart rate still remains below 60 and it goes, you have given epinephrine, it's not coming up, think of other etiology. Is it a pneumothorax there? Is it some hypovolemia? Like I said, sometimes the history tells you, if there is a motor vehicle accident and the mom was bleeding, you assume that there is some placental abruption and baby might need blood earlier, or the fluid resuscitation. There are a few boxes there. One is Mr. SOPA, one is target preductal sat, and the oxygen requirement. Again, just pause the slide, look at it so that you know it. So now few word about different areas resuscitation. Like we said, we are going to talk about it. So if you are in a hospital and the delivery is happening in the delivery room, this is the best scenario. You can follow the NRP recommendation. Most of the things are going to work there. So you don't have to be worried about their monitors. You have other stuff. So first column, delivery room resuscitation is not a problem. Now what about if the delivery is happening at home and EMS is attending it? Again, remember, in that scenario, your ventilation should be from the self-inflating bag, because you don't need an compressed air source for that, which is really ideal if you are resuscitating in home deliveries. In home deliveries, the point of care ultrasound is very handy. Most of the EMS, they have it, so they can just put on the chest and they can count the heart rate rather than going for a stethoscope or listening to the umbilical cord or palpating the umbilical cord. In outside delivery in home, umbilical venous catheterization is not really recommended. Interosseous is better, which we talked about, because EMS are trained in that. So that is something very important. The other thing is, if this baby's after resuscitation needs to go to the hospital, so you cannot do mask ventilation. If you're not intubating the baby and you are doing mask, so laryngeal mask is ideal. Just insert it and you can bag the baby on the transport and transfer, rather than having a facial mask on the face. That's not going to last during the transport. And again, the same thing in outside delivery. Remember, the cardiac compression to ventilation ratios remains 3:1. So please remember that. You don't have to follow PALS when you are attending a delivery outside the hospital. What about if the resuscitation is happening in the NICU, in the NICU? Remember that in NICU, basically the resuscitation is etiology based. If you are dealing with shock, it's different. If you are dealing with the spontaneous perforation of the intestine or necrotizing enterocolitis, it was a BPD, the baby has lung problem. If it's a heart condition, if baby has a supraventricular tachycardia, so your resuscitation is really going to base upon the etiology. So it's etiology based, not age based, that 14-day-old baby should be doing this, 28 days old baby is doing this. Just remember that you have to go with the etiology. The other thing, most of the NICU do have TPs available when the babies are there, so you can use that as a ventilation device. Ratio remains the same. Remember, we don't follow PALS, we follow NRP. And like we said many times, most of the problem in newborn is ventilation, is respiratory, not cardiac, as compared to bigger babies or adults, which is cardiac. And again, one thing is very important in NICU, that your saturation target is different than in the first two columns. When the delivery is happening and the baby is within the first few minutes of life, you follow the oxygen target saturation. If the baby is in the NICU, you don't have to do like 1 minute, 2 minute, 3 minute, 5, because the baby is already older. So there is no point follow the oxygen target chart, which is understandable. And we talked about the other thing which is very important to remember, that in NICU, most of the time the babies do have central lines. So baby have a PICC line or a Broviac, or sometimes has inside to the umbilical venous catheter. So you don't have to worry about getting an interosseous or any other IV access or PIV, because most of the babies do have central lines. So this is about NICU. Now, what about if the baby's in the ward, postnatal ward, pediatric ward, or baby was nursed in the nursery, or baby is with the mother, and a need for resuscitation arises? Baby is apneic, baby stop breathing. As what should you do there? The most important part is that you should have a self-inflating bag available in every room of the postnatal ward, so they don't have to run around. And here it's very difficult to get to the monitor, so your stethoscope comes handy in auscultating. And again, because the patient is still fresh in terms in the nursery and the ward, if they are still like a few hours old, umbilical venous catheterization is better. If the newborn is in the ward, the baby is admitted for hyperbilirubinemia, and baby is like 6-7 days old, then probably interosseous will be better than the UVC. So you make the call depending upon the age of the baby here about the IV access. Again, remember, saturation targets changes. It doesn't apply to the post-delivery right away, because now the baby is older, so you don't have to follow the minute by minute saturation target, which we follow in the home deliveries or the delivery room resuscitation. The last thing which we have to do, don't run with the baby and try to bring the baby to the resuscitation area, because that can cause some accidents. Ideally, most of the hospitals should have some provision in every bed with the mother. They should have, like many centers have care by parents kind of a setup. So there is a resuscitator in the room already available. You put the baby there and resuscitate there. Don't try to take the baby. But again, depend upon the scenario. If the NICU or the ward is just next door, you can take the baby quickly. But again, this is not advisable. The last thing which we want to say on this slide is there are two other presentations which we have separately on these topics about delivery outside the room, which some scenarios. We have given you scenarios so that we walk you through what to do, and also certain scenarios in the NICU resuscitation. So if resuscitation goes outside the delivery room, either in the postnatal ward or in the nursery or in the NICU, certain things are different, and the new textbook have 2 chapters dedicated to that. So please do read that as well, and also you can click the link and watch these videos. Quick exercise. Again, this is just some questions. You can pause the slide, try to answer those, and see what your score is. These are the answers given, and so that you can interact and see where you are. These are certain references.